So this talk will cover the acute coronary syndrome. During this talk, I'll review the relevant definitions, outline the presentation and assessment of a patient with acute coronary syndrome, talk through the initial management and reperfusion therapy, and finish off by talking about secondary prevention. Acute coronary syndrome, or ACS, is an umbrella term for any acute myocardial ischemia caused by atherosclerotic coronary artery disease. And it covers three conditions: ST elevation myocardial infarction, or STEMI, in which there's a full thickness damage to the myocardium caused by a full blockage of a major coronary artery. We have non-ST elevation myocardial infarction, or NSTEMI, in which there is a partial thickness damage to the myocardium, and that's due to partial blockage of a major coronary artery or full blockage of a minor coronary artery. And finally, we have unstable angina, in which there are ischemic symptoms consistent with myocardial ischemia, but without a related increase in cardiac biomarkers. So to sum up, STEMI and non-STEMI have positive troponins, while unstable angina has a negative troponin. This is a simple comparison of the components of ACS. As the name suggests, STEMIs will have ST elevation, but may also have other ECG changes, such as reciprocal ST depression or T-wave inversion. Non-STEMIs will not have ST elevation. They may have other ECG changes, such as ST depression or T-wave inversion, or they may have a completely normal ECG. And the same is true of unstable angina. There will be no ST elevation. There may be other ischemic ECG changes, or it may be entirely normal. STEMIs and non-STEMIs will both have associated rises in troponin, whereas unstable angina will not. The classic presentation of ACS is of central crushing chest pain that may radiate to the arm or jaw. The patient may be sweating, may be nauseous, and will probably be feeling pretty anxious. As with any other acute condition, you need to approach it using the ABC framework. Baseline observations should be recorded, and it's crucial that you obtain an early ECG. Routine blood tests, such as UC&E's full blood count CRP, should be requested, along with a troponin, and a chest x-ray should be ordered. Up until fairly recently, initial management was simply morphine, oxygen, nitrates, and aspirin. However, recent guideline changes mean it's a little bit more complicated than that. Morphine should be administered, and that's usually between 5 to 10 milligrams IV, and it's titrated to effect. This is obviously an analgesic, but it also helps to relax the patient and reduces myocardial demand. Oxygen is now only given if the patient is hypoxic. Oxygen is a vasoconstrictor and may constrict the coronary arteries, and that's why we don't just put 15 litres onto everyone who comes in with chest pain. A few sublingual sprays of nitrate spray should be given, and a 300 milligram aspirin tablet should be given to the patient, and that should be chewed to increase absorption. Another change is that we now give 300 milligrams of clopidogrel as well. For patients with a STEMI, thrombolysis is the administration of tissue plasminogen activator, or TPA, and it's for STEMI patients who can't receive PCI within 120 minutes. It should be administered as soon as possible, and if thrombolysis fails, then patients should be considered for a rescue PCI, in which they have a late PCI to remove the clot. There's a long list of exclusion criteria, including recent surgery, recent head injury, or underlying clotting disorders. Once you've got the patient through the initial presentation, it's important to begin secondary prevention. This includes lifestyle modification, such as advising the patient to stop smoking, to improve their diet, and to take a gradual exercise. It also includes psychological support. Having a heart attack can be a very stressful experience for patients, and they may not know what to do regarding their work and various other aspects of their life. There's also a list of pharmacotherapy that should be prescribed lifelong. That's a maintenance dose of aspirin. Your clopidogrel or ticagrelor should be continued for 1 year after the event. A statin, such as simvastatin, to reduce cholesterol. A beta blocker, such as atenolol, and an ACE inhibitor, such as ramipril. So to summarise, a thorough and urgent assessment should be taken for all patients presenting with chest pain, and that must include an early ECG and troponin. Patients presenting with ST elevation need urgent revascularisation, and lifelong secondary prevention is required. Thank you.